Hello and welcome back. I hope nobody is hungry after that snacks and pureed foods. So thank you for rejoining us. Ooh, I'm stepping on things I'm probably not supposed to step on. So before we dive back into the presentations, I'd like to mention the Rune flyer that you'll find on your table. Rune is a centralized platform for people navigating ALS-MND. The website and app version have short-form Q&A videos from ALS-MND experts, people living with ALS-MND and caregivers answering thousands of top questions that come up during the diagnosis and treatment journey. It is free and is available throughout the world, though it is in English. And I encourage you and your teams to check it out. And if you do check it out, you may be seeing myself and John, the next presenter, on it. So you can ask me about it as well. So I'd like to welcome John Costello up for his presentation, Message Banking Process, Updated Process and Considerations.
Hello, I am delighted to be here to talk about message banking process. Richard, I won't get my water on your computer. And the updated process and considerations. I think that all of us here would agree now that our voice is our acoustical fingerprint. It is a representation of who we are, and it is something that we really feel is an important part of our expression. The power of personal voice. You know, we hear someone, we pick up the phone and someone says, "Hi, it's me," and you immediately recognize not only who the person is, but everything about that relationship. The good, the bad, the ugly, the funny, etc. It all comes with just hearing that. The power of personal voice. The role of familiar voice. Not only is it important for us to have our own voice, but it's important for the people around us to hear our voice. If I had more time, and I don't, because Sarah Feldman told me I do not, and I'm afraid of Sarah. So if I had more time, I would be able to show you countless videos, not only of people, but even animals responding to personal voice. And I think over the years that we've been talking about this now, many people recognize that. There are physiological impacts. So there was research done in 2010 that highlighted that when a daughter heard her mother's voice, there were physiological changes to oxytocin, neurohormones, in that daughter that were similar to when their mother embraced them. So we know that voice is really important. I am so thrilled that in 2016, I got to first introduce the whole concept of message banking. It feels like that was a very long time ago in lots of ways, but at this conference in Ireland, introduced the concept of message banking. And I have to tell you, at that time, there were some people, some kind of prominent people in this field who said, I don't think that's something that people with ALS will want to do. I don't think people will want to take the time to do that or will embrace that. And now it is broadly something that is used and adopted nationally in the United States and internationally. Until recently, the best outcomes for message banking have required using a handheld recorder, because we've had very specific stipulations for how to get the very best recordings. And for those of you who may not immediately remember, message banking is capturing entire phrases or sentences that are then able to be presented, used in an augmentative communication system exactly as you intend for them to be heard. So the difference between using a synthetic voice that currently, if I wanted to say, "I'm so proud of you," even if it sounds a lot like me, currently, will sound more like, "I'm so proud of you," as opposed to a banked message, "I'm so proud of you." So, we are able to capture so many of those messages, and for a long time have needed a high fidelity tool. I also want to point out that when we first introduced the concept of message banking and all of us started to embrace it, it became something that lots of people in the augmentative communication world, many technology companies, embraced as well. But they did it a little bit differently than intended. They did it from the perspective of, well, we're going to build in the ability for you to record into the device. And while that is nice, it kind of ignores the fact that a good feature match process, a good selection of the best tool and technology, if someone ever needs it, is done when someone needs it. Because you don't know what features you really need until you need it. And so if you get a device ahead of time and start recording messages into it, you may actually be someone who has a technology that if you need it, it's not the right match. Or we've had many people who actually, they have technology and it's no longer supported in the market. So while it's great, it's been embraced that way, the authentic capture proactively messages is something we've really tried to focus on. It's intended to be technology agnostic. It's not done to a specific tool, but it's intended to make sure you have all options available to you if you ever need it. It's intended to create an insurance policy. We all understand an insurance policy. We want to have it. We hope we never need to collect on it, but we're comfortable it's there. And hopefully, we're wasting people's time asking them to capture messages, but at least it's there and someone's comforted by it. And finally, the goal is, and our mantra is, least amount of effort, time, and energy for the highest quality of outcome. So in 2017, because lots of people talked about there's a lot of work that goes into managing these files, I was so fortunate through the ALS Association and the Prize for Life to receive a grant to be able to create mymessagebanking.com, which is a free site that allows people to upload messages, have them fully transcribed. Now transcribed in 2018, we expanded into multiple languages, as you see here, so that they can all be in that system at the same time. Most of the developers of communication devices changed their software so that it could connect to this site and auto-download the messages, the voice, the text, create the pages, etc. So a lot of the manual work is done. And as you can see, it's also in multiple languages. Here is just demonstrating how we have used it in Italian. In 2019, introduced the concept of double dipping. Double dipping is really intended to use those banked messages. Remember, make sure that we get the most out of someone's energies and efforts. Use those banked messages to also create a synthetic voice. And so that's something that thankfully now many companies have started to do. It started with Acapela, and Acapela actually created and partnered with funding sources around the world to make sure that people can have their voice and not have to pay for it if they can access one of these funding sources. There's also the ability to request double dipping from Speak Unique and VoiceKeeper, and more Model Talker has indicated that they're willing to do it. In 2022, however, we really wanted to look at how can we, in fact, for a long time we've looked at how can we make this easier? How can someone not have to have that handheld recorder? And how can someone bank messages at will whenever? And we repeatedly were looking at apps and trying to figure out what the best apps were And you might say, well, gosh, John, there are so many apps that let you do recording. But the important piece was that it was seamless and easy, that we could record in .wav file format, that it didn't require many steps to manage it, and that I could seamlessly tell it, or fairly seamlessly tell it, now auto-upload that to mymessagebank.com so it can sit there, be transcribed, and then be imported into a communication device. So we have come up with a way to do that, and also have detailed, because many people have said, you know, what is the clinical process? So Martine Smith from Dublin, Ireland, and I detailed in this article in 2022 the entire model, and I don't have time to go into it, but if you're interested, the article is available, and really kind of went through the whole clinical, the breakdown of how message banking is introduced, and how then the concept of turning that into a voice banking option can also be introduced. The unmet goal, we want to use readily available technology. We don't want someone to have that Zoom recorder, and we want it to be able to be fully managed in mymessagebanking.com. So after looking at many, many different apps and trying to find something that would work fairly seamlessly, we identified a free app, the AVRX, and I thought it was going to be a very technical name to it that stood for, but it was the Awesome Voice Recorder app is the name of it, that one can use. And go ahead, move forward.
This video review will cover how to complete message banking and upload to your mymessagebanking.com account, all on your iPhone. And we're going to
This is a compilation of a much longer video that shows you all of the steps at this QR code.
AVRX voice recorder. To set the stage, when you are using the recorder, you'll hold the phone up to 6 inches away. Now tap here so you can go back. And now you're ready to start recording until you've recorded all of the messages you wish to do. But we want to create a folder specifically for your banked messages. To do that, so let's look at the actual upload to mymessagebanking.com. In order to allow you to now go to your browser, and when you've selected all that you wish to upload, tap open. You'll then see those messages appear in the screen. It will begin transcribing those, and open your mymessagebanking.com account so you can listen to those recordings there.
And again, I would have shown you the whole video, but Sarah told me I couldn't. So at that QR code, you have access to that video. Now, like everything, technology is constantly changing and getting better. So I will tell you, there are a whole lot of things that I wish that we could do better right now. I wish it was not just an iOS app. We've looked at multiple applications, and we keep running into there being so many steps that when we have tried to do it, and I should mention the video that was put together, several people living with ALS who are going through the process with me helped me create the video. So I originally created steps, and then people said, oh, you need to include this step, this step. When I went home from your office, I forgot that you told me how to do this. So it's quite detailed. And when I've tried to do that with other apps, people have told us, it's too much work, it's too complicated. So we're working on it. It's not ruled out, but this is a start. So what we want to be able to do is continue to use banked messages to double dip, because of course, not only having those recordings is important, but then being able to say anything you want when you want to say it in a voice that approximates your natural voice is critical. So this whole idea of double dipping remains key. And while currently, as I've pointed out, you can double dip with several strategies. There are a couple of options. So most recently, Apple, as you know, has come out with the ability to create your own voice. And so I will show you this very quick video where I was able to use all my recordings from my Apple, to create my Apple voice, and then actually export those and create an a cappella voice, because not everyone is going to have an iOS product be the best feature match. And currently the Apple Voice, and for the foreseeable future, the Apple Voice will only work on an iOS product. There are phenomenal iOS augmentative communication options, but one should not be locked into a technology. Remember, technology agnostic. So with this process, we can export those and then create a voice in presumably all of the voice banking options. I've been able to do it rather seamlessly with a cappella. If we could run that video, it's not running for me. This is where I get to say, hit it, guys.
So now that my voice has been created with Apple, I want to download all of my audio recordings and use those to essentially double dip. I want to see if I can use them to create a voice with a cappella so that I have a voice product that will work on non-iOS products. So I'm going to go to my settings. I will go down to accessibility, which I just missed. There it is. I'm going to then go down to personal voice. I will touch my voice. I'm going to now tell it to export voice recordings. And I'm going to airdrop them to myself. Okay, I have now transferred my Apple recordings from my phone to my computer via AirDrop. I then created a new My Own Voice a cappella account, had it approved through a funding source, and so I'm now in my account. If I tell it I want to use my own recordings, I can see, here's my name, my recordings are in English. The voice banking format is not from mymessagebanking.com. It is from Apple.
So they built in
I'm going
Apple
to now
download.
go and choose files. As you see, it says only zip files. Choose file. Go to my desktop. Here is my recording. Open that, agree, and upload.
And then this goes through, it uploads, and when it's done, it just tells me that it's sent to create the voice. So can we use message banking? Can we actually double dip? So I have very fortunately been able to talk with folks from Apple a number of times, talk with their engineers about what's great about what they've done, what we hope will be better to serve a broader need. And so I took it upon myself to try to double dip. Don't get excited. It is not great, but I want you to see this process. If you could run this video, please. It's 1 minute.
I'm creating a personal voice with my iPhone. So I'm going to record my own messages. My name is John. Please don't hang up the phone. It will take me a minute to respond.
So that's their prompt, and in my typical way, I ignored the
I liked
rules.
Dan Harris's book. Do they have an audio version of that as well?
So now let's compare my original Apple Voice, and I'm using this in a text-to-speech app where I could easily just upload it on my phone.
This is the voice when I follow the rules.
Okay. So
Now I'm going to go to my voice settings again. And I'm going to select voice. This time I'm going to select John's own phrases voice. I know that I have to have it incredibly slow, so I'm going to turn the speech rate down here. And now, so clearly trying to use custom phrases currently is an epic fail.
epic fail. But first, we can use message banking in a new way. We can double dip. We can create voice with Apple, and they are listening. I have no idea what to expect, but I got an email last night from Apple saying when you get home, there will be a package at your house. I'm hoping it's going to be a brand new tool that's going to let me do what I want. I don't think so, but there is hope moving forward, and things have come a long way since we introduced this at this conference in 2016. And the bottom line is everybody can message bank, and it is free. The management of it is free. And once those messages are there, they are then available for you to hopefully be able to use in a voice bank process of some sort. Nobody should not be able to preserve their voice. Thank you.
Thank you so much, John. Thank you for following the rules. I also am very impressed with how far everything has been moving forward, and just keep looking forward to more. I know there is one question online.
This is from Salma in Queensland, motor neuron disease. Is there a way to take the custom phrases used during the voice banking process and download them into message banking instead? In my experience, clients find it difficult, daunting to complete the 550 phrases to complete double dipping.
So great question, and there are a couple of answers that should be embedded in there. First of all, if you're doing the prompts to voice bank that the companies require, as you just saw a few of them, they're not things that you would typically be saying. They are sentences that have been selected to identify the co-articulated sounds in language that are needed, that then can be supported through the use of artificial intelligence to be able to come up with a voice that sounds more like you. So while you could export your recordings, and many of the companies allow you to take your voice bank recordings and export them, they are not something I've encountered anyone has found to be useful. The 550 is really important also to point out, because while 550 is sort of the base number of messages that is expected in order to double dip, the real key is they have to be super, super high quality. If you have fewer than 550, I would absolutely encourage you to submit those and ask for a special dispensation, but know that if they are not good quality, you're not going to get a good outcome. But many people have really high quality in their first 100, and at the risk of having my hand slapped for saying this out loud on a microphone, a voice can be created with that.
I don't actually think we have time to take any questions, but John will be here, so find him. Thank you. See, John knows if he goes over, he won't have time for questions. Maybe that's it. Should I do this now? Or later? Now? Okay. I just wanted to remind people about the Rune, and just one thing I might have not said, because I probably didn't say it, is they are looking for people who want to contribute as well. So if you scan in or take a look at this, you can also become a contributor. So up next, we're going to virtually welcome Lynn Hills, Maggie Hevicon, and Simon Fieldman, who will be presenting evaluations on the use of eye gaze driving in powered mobility for clients living with MND.
Thank you for inviting us along today to share our experience with eye gaze driving in powered mobility for those living with motor neurone disease. We've been really fortunate to be a part of one of the first eye gaze driving experiences in the UK, and we hope that this presentation will allow us to share our experiences so far. Just to give you an overview of what we plan to cover in this presentation, we will look at the role of the MND Wheelchair Support Service and what we do. We'll look at eye gaze driving and the technology involved, and present a couple of case studies that we have recently had the opportunity to be a part of. We will outline some of the challenges in its provision, along with its advantages and disadvantages, and share our thoughts in the development of a clinical decision-making tool, which we hope will help with the initial screening of clients and conclude with our recommendations in taking all this forwards. So just to tell you a little bit about ourselves. For those of you who are not familiar with this service, myself and my colleague Maggie work as wheelchair therapists as part of the Wheelchair Support Service at the MND Association, and we are supported by a Wheelchair Service Coordinator, Anne Buchanan. We work with wheelchair services both locally and nationally to improve pathways and provide timely access to assessment and provision, and we're able to support education and training. We support clients in their wheelchair provision and offer education and advice regardless of geographical location. We work with manufacturers in the development of products to meet the needs of our clients, and this also includes a system to prioritise and fast-track orders. Maggie and I clinically support 2MD care centres in London, and as part of our role, we've been able to explore new technologies and evaluate their use. And this has afforded us the opportunity to trial eye gaze driving technology with Ability Drive with a couple of our clients, which we'll share with you today. I'd now like to introduce Simon Fielden, who's from Rahana Life and is the sole distributor for this technology in the UK. Simon.
Thank you, Lynn. I'm Simon Fielden, a registered clinical scientist. I worked in the National Health Service for 30 years across a range of rehabilitation services before starting a business, Rahana Life, and we specialise in assessing for and supplying technology for people with an upper limb impairment. So eye gaze driving is achieved using a system called Ability Drive, developed in the US by Tolt Technologies and distributed in Great Britain by Rahana Life. The magnified image on this slide shows the communication tablet camera view overlaid with arrow boxes that represent the direction of travel for the wheelchair: forwards, reverse, left and right, sharp turns, and left and right forward half turns. The user drives the wheelchair by gazing at the appropriate arrow box. The chair will then drive in that direction for as long as the user's gaze is on the box. The user stops by taking their gaze off the arrow box, or closing their eyes, looking away, or selecting the settings box, which is shown at the bottom right of the screen. The system is designed to fail safe, i.e. the chair stops if there is a fault condition. The settings menu allows the user to change a number of settings, such as arrow box size and contrast to improve the camera view, and also to exit the software and return to their communication software. The system can also be used to operate the seating controls of a wheelchair. Thus, Ability Drive allows a user with no physical movement to operate a wheelchair. There are over 1,000 users across a number of conditions, including MND, in the US and 6 current users in Great Britain. Successful adoption of this system requires cooperation between the providers of the various technologies, that is, the wheelchair, the communication device, and Ability Drive. Ability Drive software is loaded onto the communication tablet, and care is required to integrate this program into the program select system that the user is operating. In other words, the user is able to switch easily between the software packages they use on their tablet. The wheelchair must be set up so that the chair drive characteristics match the Ability Drive and user performance. In other words, the optimum chair speeds, accelerations, and decelerations in all directions are carefully selected. It is recommended that a gyro, these are off-the-shelf standard supply items, is fitted to the wheelchair to improve directional stability. Clear channels of responsibility must be established for maintenance of the system prior to supply. This requires early dialogue and agreement between the relevant services. This will allow for an assessment or trial of Ability Drive to go ahead, and if successful, subsequent supply. Ability Drive can only be supplied with compatible wheelchair systems and communication tablets. Tolt Technologies have a comprehensive testing program with these technologies to ensure safety and compatibility. Current wheelchairs that use ARNet and Lynx drive systems are compatible with Ability Drive. And in terms of communication devices, Tobii, SmartBox, Liberator and Jabla communication devices are all compatible. I'll now hand over to Maggie.
Thanks, Simon. We'll now run through 2 case studies that we've been involved with. Both of these clients were well known to their local wheelchair services and had powered wheelchair provision in place. They had both been unsuccessful in trialling alternative and more specialist controls and were reliant on a carer to use the attendant control for driving and changing position. Both were proficient eye gaze users, and this was their most reliable active movement. Our first client has a diagnosis of PLS and has been known to the wheelchair service for many years. She has a Quantum-powered wheelchair on loan from the wheelchair service and is no longer able to independently drive the wheelchair with a joystick or alternative specialist controls. She has very limited reliable active movement due to increased tone and is a proficient eye gaze user. She has an excellent support network and a motivated carer who embraces technology, and living in central London, her driving goal was to visit local galleries and museums so she could choose where she wanted to go and what to look at. So here is a short video of her doing just that, wandering around the local London museum and going where she wants to go. Case study 2 is a client who has provision of an Indivacare TDX through the NHS wheelchair service. He's no longer able to manage any controls for independent driving and has no accessible active movement. He has recently been trachy-ventilated and is currently residing in a care facility with plenty of space and all services integrated under the same roof. The client's goal was to achieve independent mobility, to change his position himself, and to walk alongside his son. What became apparent very quickly was that his existing equipment was not compatible with the integration of the eye gaze technology, meaning that both the wheelchair and the grid pad would both need replacing, which his local services were willing to support. He was therefore set up in the assessment chair from Rahana Life for the trial. This allowed him to trial the technology and see what it would afford him. The results were simply amazing for him. There is a voiceover to the next slide, a video which has very kindly been provided by his wife, Jess.
My beloved husband Sean was only 32 when he was diagnosed with MND completely out of the blue. We had a tiny baby at the time. Over 7 years on, Sean can't move at all, nor can he speak or breathe independently. But he can type with his eyes using eye gaze. Being in the correct body and head position enables Sean to still communicate with his little boy and still work on the economics that he loves. But we have struggled for years to find quality care for him at all times. When he's in the wrong position, it's hard for him to breathe and impossible for him to communicate. This jeopardizes his safety and leaves him with a lower quality of life. If this technology could help him to move and position himself independently, that could be game-changing for him. It would enable him to keep talking to his young son every day, keep in touch with his family and friends, and to keep up his work as an economist, which he loves so much.
Whilst the technology has undoubtedly created many opportunities for HARD2 clients, both in having independent mobility and being able to change their position and posture independently, it has presented us with a few challenges in how this technology can be integrated into their wheelchair and communication device. It became apparent that before any assessment can take place, there should be a process to go through in order to ensure that everyone's goals are realistic and to identify what needs to be in place for this to be achievable. Some of the challenges for us were related to the compatibility with the existing provision that the clients had and the need for replacement equipment before the eye gaze could be provided. This places pressure on already stretched budgets and requires clinical staff who have the knowledge, skills and time to support the complexities of this equipment. Funding needs to be considered in regard to who will fund the driving technology, and the funding channels for any changes in wheelchair or communication device need to be agreed. Just to briefly summarise some of the advantages and disadvantages we have experienced with the cases we have been involved with so far. The eye gaze system offers independent mobility and control of seating position where all other special controls have failed. The system is intuitive for clients who are already competent eye gaze users for communication. The quality of life measures used so far have had positive outcomes for the clients and their carers, showing they now have some control of their mobility and posture restored to them. The technology is a non-contact system which can easily be used with other clients, unlike the other systems that are vulnerable to breakage and would need decontaminating before using with another client. However, the cost of this system is high compared with other developing special controls and can be 2 to 3 times more expensive than the alternatives available. The NHS wheelchair services are not in a position to fund this technology on their own, and sourcing alternative funding is difficult and time-consuming. This makes it very difficult for clients to be offered the opportunity to try this technology if the funding and technological support is lacking. As an association, we've been approached for advice on using this technology with other clients, and therefore, given all the considerations covered in this presentation, we felt it would be beneficial to develop a clinical decision-making tool to aid this process. It's very much in its infancy, but some of the content is covered in this slide. We would welcome any thoughts or ideas on this, or if other countries are already using this and have something similar, we'd definitely love to hear from you. So I'll now hand back to Lynn.
Thanks, Maggie. If we consider our recommendations on the use of iGaze Drive-In, iGaze Ability Drive is an exciting technology which will allow powered wheelchair users to maintain their independent mobility when they are no longer able to use other driving methods. We have learnt through a small number of clients that its use and application need to be carefully considered, and all services need to be engaged to make this a reality for the client. It is important that we continue to share our experiences to further our knowledge and exposure to these systems and truly understand the impact on the client, their family and carer support systems, as well as the services involved in their delivery. We hope that through the development of the clinical decision-making tool that this will support the process and help in managing expectations for everyone involved. As a final note, this was sent over from our client in case study 2. He makes reference to the MND promises and in particular highlights Promise 3. Promise 3 states, every day with MND counts for people with MND. Technology can help life to be the best it can. And he would like to finish by saying, let's hope we can find a way to move this technology forward and make it accessible for all. It would be simply wonderful. Thanks so much for listening to us today. Here are our contact details, and now we've got some time for questions.
Thank you so much, and thank you for joining us. Are there any questions to start out? Down here?
Hi, is this on?
Yes.
Okay. My name's David Busek. I'm a patient fellow from the U.S. I found that really exciting to see, but one of the things I noticed is that the panel is directly in front of the people's faces in the videos we saw. So I'm wondering about their ability to, say, see the art that they've gone to look at, but also collision avoidance, both for forward driving when they're concentrating on the panel, as well as for turning and backwards, which I know in my own wheelchair, backing up can be a bit hazardous.
Simon, do you want to answer that one?
Yes, I'll respond to that. So I don't know if you noticed, but the view that you have when you're using the system, you have the camera view from the tablet, so you're able to see what's in front of you. The smaller the communication tablet you have, the better, because what people do in reality is use a lot of peripheral vision around the device. And that seems to work very effectively. In terms of reversing, you can actually switch the tablet camera, so it's the front-facing camera that activates. And although you see most of your face, you do see a little bit of background of what might be behind you. So those are the kind of systems that are in place to help with that challenge.
There's an online question as well.
This is from Milena Bastian from the University Valgarist. Hi, my name is Milena from the University Valgarist in Zurich. Do you have any contacts here in Switzerland right now?
Okay, so my understanding is that the American manufacturers of this technology, who are Tolt Technologies, are working with, I think it's a German supplier, to provide this across mainland Europe. So what I would advise you to do is go to the Tolt Technologies website and see the latest news.
There's a question down here.
Hi.
Hi.
Am I on?
Yeah.
Yeah. I'm not thinking aloud. Is there a possibility of a future hybrid model where we can have auto technology in the future, where the future will go on its own. When I believe that I'm not around, and to control mishap, I have not idea. So like a hybrid auto plus user intervention.
Dr. Manji, I actually didn't catch all that. You have an eye gaze?
No. I'm toying with an idea.
You're toying with the idea.
Yeah, because Tesla. Yeah. Like it's not auto driving more.
I can't hear.
Yeah, auto. Driverless.
Driverless.
Wheelchair.
So a driverless wheelchair, not even using the eye gaze.
Exactly. And a hybrid where I can control by eye hand also.
You can do both. You have a mix of like a hybrid.
Right.
So it would be somewhat able to run on its own, and you could also do eye gaze. Oh,
right.
And you want Tolt to look into that?
I know there are some.
Go ahead.
There are some developments actually through UCL, and they are looking into sort of different technologies to drive wheelchairs without sort of some kind of control. So I think it is just watch this space. There's a gentleman called Tom Carson that's doing quite a lot of work on that at the moment.
Jesse, how are we doing?
I will mention to Tolt that they should be looking into this.
Maybe hook up with Tom, Simon.
Yeah.
Is there another question? It's very hard to see you all from up here. I just want to comment that I find that driving the wheelchair with your eyes is such a multidisciplinary thought, because it's the speech therapist who's usually working with the AAC, the occupational therapist who may be working with the power wheelchair and how to access the AAC, and the physical therapist who also might be helping to determine when there's a need for the power wheelchair. And the neurologist is very important as well. But the multidisciplinary team that has to go into this decision-making process, I just think is true multidisciplinary look. So thank you all very much. And
you're welcome. Thank you.
Thank you.
And I just want to remind people who are asking questions online that you can reach out to the presenters online as well. All right. So next up We have Invest in Your Voice, How a Novel Co-Designed Voice Banking Service Supports People with MND with Nicholas Jackson.
Richard? Is that all right, Richard? Do you mind if I move your laptop? Thank you. Good morning, everybody. My name's Nick. I'm a speech pathologist from Calvary Healthcare Bethlehem in Australia, and I'm going to be presenting the results from our recent study titled Invest in Your Voice, How a Novel Co-Designed Voice Banking Service Supports People with MND. Alrighty, so before I continue, I would just very quickly like to acknowledge that our research has been supported by Calvary Healthcare Bethlehem and the Alawali MND Victoria Research Grant. We've consulted with people living with MND ALS, their carers and other organisations, and additionally our speech pathology department has been involved in the research phases and development of the new clinic model. Very quickly I'm going to run through a little bit about our service. So we're a public health service specialising in progressive neurology and palliative care. The speech pathology team provide inpatient, outpatient and community-based services, as well as offering a secondary consultation service to support local and regional clinicians working with people with MND across the state of Victoria. We're the largest provider of services to the 500 people living with MND in Victoria. An important part of our role is to support people with their ongoing communication needs. And this includes supporting people with voice banking for future use to ensure their ongoing communication and social participation. So we've already heard from John about message banking, which is a very exciting presentation. And I feel very humbled to be here as well after John and before Richard. So what I want to talk about is a little bit about voice banking, which John's already kind of talked to. So it's a process that involves recording a person's speech, which is then used to create a synthetic or digitized voice that can be banked and stored securely for later use when and if required. So rather than using a generic default male or female voice, the synthetic voice can be loaded onto an everyday device such as an iPhone or iPad or a specialized communication device. The output voice will sound like the person's own voice, a factor that we know is critical to the acceptability and therefore the uptake of voice banking. Voice banking's become more accessible, less time-consuming, with many programs now available on the market. However, it remains a complex and challenging space for some healthcare professionals due to the overwhelming number of voice banking services and the lack of evidence to support and inform decision-making and implementation. As outlined by Richard and his colleague Stephen Block, the reality of using AAC and voice banking for communication is poorly understood by people living with MND and healthcare professionals. So why research voice banking? And I suppose we're coming from a bit more of a humble beginning than where John's clinic is at. So historically, there's been very low uptake of voice banking in our service. We know that early uptake is important so that the synthetic voice output will not be impacted by speech changes. You know, if it's done after the onset of speech changes, the quality of the synthetic voice will be impacted and voice banking may not be possible if it's left too late. So previously we trialled providing information using pamphlets, an email follow-up, registering clients with voice banking accounts on their behalf. No success. Sending people out headset microphones So they could do the recording at home, also didn't work. And a group delivery format where we had everybody kind of together, where we could set up the recording on their behalf with some staff support, also unsuccessful. So we then realised we needed to partner with our patients to better understand and meet their needs. And so we embarked on a research study back in 2022 to develop a co-designed voice banking service. So just quickly, this is a phase 1 of the project, which involved survey, patient carer interviews, staff focus groups. The outcome was the co-designed voice banking clinic model that I want to talk to today. We previously reported on this data at the San Diego conference, so I won't spend much time on it now, but here's a summary for your reference. Okay, so in summary, the key elements of our co-design model, which phase 1 resulted in, included practice change, early referral. So using the phase 1 results, we developed and delivered an education module for external and external referrers. We also have begun to adopt patient-centered lexicon to talk about voice banking in a positive and acceptable light. And speaking to what John said before, the language of investing in your voice. Establishment of voice banking clinic infrastructure and implementation of a systematic process now underpins our model. So we're using systematic audit steps and detailed decision-making guidelines to contribute to clinician confidence and ease for patients. This involves tailored informational counselling, addressing the knowledge we know our patients want, as well as a demonstration of a clinician's synthetic voice, immediate booking for voice banking with our allied health assistant, voice shaping, and then voice delivery at an agreed time points. Which brings us to today's project. So what I'll be focusing on today is the evaluation. So the first part was a database review, which reviewed the changes in completion rates, rate of uptake, and time taken from diagnosis to recording. And then a survey to better understand the perspectives of people living with MND who have gone through our new model. So, how did things look? Also, how did things change looking at our voice banking database? So this is a like-for-like 9-month period, pre and post implementation of the new model. Firstly, while we see similar rates of people diagnosed with motor neuron disease to our outpatient service, in 2023, post-implementation of the new model, we see a significant change in outpatient uptake of voice banking, with over 20% of all our patients referred to the service completing voice banking. Also, interestingly, we see an incidental shift in the practice in the inpatient service, just kind of by contagion, despite it not being the focus of the voice banking clinic, which is exciting. Looking at the database review, looking at the change in the completion of voice banking. So for the savvy audience member, you'll notice that there are 2 very different time periods here that we're looking at. So with the pre-2023 time span, we had expanded it to capture as much data as possible, so it's a 2.5-year period, and also looking at taking into account the impact of COVID at that time. And then the 2023 clinic model, we're still looking at the same 9 months. So you might notice that there's a few more voice banking clinic referrals in that 2.5-year period to the 2023 clinic model, an increase of 337.5%. Completion rates were fairly similar, but improved still in the new model. But the really interesting data you begin to see is the change in how quickly we're offering and then how long it's taking from when we offer the voice banking to completing the voice banking. So down from 158.57 days to just 19 days. And then also the range from a person receiving their MND or ALS diagnosis to the date we're completing voice banking. Down from a median of 462 days to 126 days. You'll notice that huge range, though, in the 2023 clinic model is because when we were also offering this model to people who had been living with motor neuron disease for a long time. Alrighty, so onto the survey results. As you can see, our participant ages are normally distributed and are in line with the literature, where the mean age at onset in sporadic motor neuron disease is 65.4 years. asking participants to think about, to answer what type of ALS MND they have. This is really actually a bit of an unexpected but important finding, that just under half of our participants didn't know their MND ALS phenotype, which has an important impact on the person's understanding of their own disease. Also, it can impact somebody's uptake of voice banking, as we know that disease progression is an important factor in decision making. Asking people to reflect on how motivated they were to complete voice banking before they received informational counselling. While we see the majority of participants were interested in completing voice banking, under half our participants were actually somewhat or not interested, which raises questions about the types of personal factors that influence the acceptability of undertaking voice banking. Asking people about whether in the new model we provided informational counselling at the right time. Overwhelmingly, yes. And you'll see that the two participants who had said no, they didn't feel the information was provided at the right time, both commented that the information was provided too late, or looked at another way, that the speech changes were too advanced. Do you think the information was provided in the right manner? And pleasingly, people felt it was. Getting people to reflect on what piece of information had the most impact on the decision to bank their voice. We see these kind of three themes emerging. So again, going back to the idea of the investment approach being something that people found a really useful kind of way to anchor, I suppose, that decision making, how easy the process and procedure was after having the informational counselling, and the ability to maintain an identity and social connection. Was there any information that had a negative impact on your decision to bank your voice? Most people said no. One person said yes, worried about it being sent to America, which is an interesting finding. I don't know what that says about Australians, but it does also raise questions given its inaccuracy, because the service that we were using, doesn't involve that. So did this person just have pre-existing privacy concerns? And does it highlight an issue with the informational counselling that we were providing? Possibly. So what worked well in your recording session? We saw these four main themes. People identifying the clinician as helpful in the process, the actual interface, and the ease of completing the voice banking, how the voice sounds. And we also just had this nice sort of collection of positive responses, with one person just saying me, as in I was the person that made it good, as in them, which is really probably very accurate. What didn't work well in your session? Three main groupings of themes. We see this kind of emergence of positive or neutral responses where people weren't really identifying that things went wrong. But again, we see people saying the output voice, the presence of dysarthria, they are identifying those as factors which really, sort of did influence their kind of interpretation and experience of that. Asking our participants how satisfied were they with the final product. All but two of our participants in this survey reported that they received staff input to record their voice in clinic. Interestingly, so one of the individuals who completed it at home with family noted that they were dissatisfied with their voice input, namely that it didn't sound like them. And it's I think important here that this was somebody who didn't believe that they completed voice banking too late. So they believed they did it in the right time frame, but they did it at home. And I think it's really interesting to note that perhaps there is really a benefit in considering that people with motor neuron disease, ALS, really do actually benefit from having the right equipment and support and professional guidance to record their voice to improve the fidelity of the final product. When do you want, do you have a preference for download time? And what we see is that most people recognise that after the informational counselling, that when the voice should be downloaded is at the time that it's needed, or that they're happy to be sort of guided in that space. So we see 85% of our individuals in the study recognising that benefit of downloading the voice when or if the need arises. And it confirms that people living with MND ALS, at least after informational counselling, perceive that voice banking is an investment rather than to be something that is immediately implemented. And ultimately, in an Australian context, this would be something which is influenced by funding models and prognostic factors. All right, let's speed up a little bit. Nick, based on your overall experience, did the voice banking process meet your expectations? Pleasingly, most people thought it did. They either exceeded their expectations or met their expectations. I'm going to keep going.
You don't have to stop. You have 5 more minutes.
Oh, wonderful.
Then you will have no questions.
Which I don't think would be a bad thing, actually, for everybody. So, can you suggest asking people to reflect on how the voice banking process could be made easier for people living with motor neuron disease? 6 themes. The environment, increasing public education. Again, this grouping of positive or neutral themes, improving the processes, helping or increasing early uptake, and also looking at how we can improve the fidelity of the final output voice. On to the discussion. So the results we provided today highlight the value of working together with people living with MND ALS to design an effective model that is patient-centred, feasible and efficient. This is important to acknowledge, this was a small evaluation. So the sample size of our participants was 15. That's important to note. But just sort of reflecting on the facilitators that were identified with the new model. So we now have these clear pathways for intervention. We've got human resourcing and time allocation, staff confidence and competence, both in the intervention and in the informational counselling. The user interface and the low time commitment were definite strong facilitators. We've been lucky in terms of, I suppose, the funding systems that we have available that have made it really possible for us to support the download for people living with MND ALS. On to barriers. Again, we're seeing this satisfaction with the output voice. And so obviously that's a space that we're keen to be looking kind of more into, and obviously an area where there's a lot of work going on. The onset type impacting quality. And I suppose that's important. In our context where we work, the clinic is a management rather than diagnostic service. So, for example, somebody who had perhaps signs starting in the bulbar region, we would be seeing them once those, often when they have quite sort of significant changes. So that's something for us to be thinking about. Hey, how can we support early uptake, considering the entry points into our service? And also, people living regionally, which meant that they weren't able to come easily into our clinic for face-to-face support and guidance. Okay, where to next? We're hoping to continue to translate our findings into clinical practice, particularly looking at early referral and how to improve uptake, streamlining our service delivery from sort of introduction through to voice delivery, continuing to develop speech pathologist knowledge and confidence, introduction of a mobile voice banking clinic, which is pretty exciting. Then this looking at how we support knowledge dissemination. So hopefully, tapping John and Richard on the shoulder, looking at creating a community of practice internationally for practitioners working in voice banking. Looking at how we support local speech pathologists to develop skills and provide them with opportunities in this space. Creating health literate resources for MND associations, for neurologists to be provided early on at suspected diagnosis. Publishing these findings. Also looking at the acceptability, investigating further the acceptability of banked voices, integration of the synthetic voice into social context, use patterns, look at developing a framework that we can help to pilot for other services. And our blue sky thinking is developing an international consensus-based co-designed practice guideline for the introduction and implementation of voice banking for people living with motor neuron disease. And that's the end.
Phew. Thank you so much. I'm sure that John and Richard would be happy to talk to you later. Take you under their wing. There is a virtual question that I would like to get to before.
This is from Kevin Robinson from Niels. A comment and a question. There seems to be a significant gap in the area of voice banking and messaging when it comes to those of us with bulbar onset ALS. By the time we are diagnosed, have processed the diagnosis, and learned about voice message banking, the speech is already significantly degraded. So the question, where are we in developing the ability to replicate original voice rate, et cetera, from previous recordings patients may have?
Yeah. And this might be a question I might be able to sort of share with John, if that's not to put John on the spot too much, in terms of where that technology is really sort of at and supporting people with MND.
Sure. There is significant ability to take what we call archived audio and edit that and submit that through what is now the double dipping process. So if there is high quality recording and it can be edited and then uploaded into mymessagebank.com, and there's enough quality that then can be downloaded, shared with one of the voice banking companies, and they're able to create a custom synthetic voice from that. It needs to be good quality, and the editing needs to be strong so that it's cutting out other noises, other voices, laughter, speaking a different language, dogs barking, all that sort of thing. But there are many, many quality voices that have been created now out of archived audio.
Thank you, John. And hopefully that's a hopeful positive response for the questioner.
All right. And do we have time for any more questions in here, Jess? Okay. So we're going to thank you.
Thank you.
I'm always, like, when I come up here, I just want to remind people you have a little bit more time left, because while I like to keep on time, I'm also very cognizant that the people in the room do not all speak English as their first language. So the faster you Australians speak, the less the rest of us, even American English speakers, can understand. So our next presentation, please join me in welcoming Marcella Sacco for Why Palliative Care in ALS, the Appropriateness of a Care Model for Managing Complexity Virtually.
Why palliative care in ALS? The appropriateness of a care model for managing complexity. This year, 2023, ISLA celebrates its 40th anniversary. We began in 1983. Until today, we've grown up. We have 64 territorial sections spread in 19 Italian regions. We did training throughout Italy. As you can see in the table, 406 training modules have been developed by us since 2009 for a total number of participants of 9,299. We published papers to help healthcare professionals, citizens, and patients. This regard the therapeutic choices of the person affected by ALS, the person affected by ALS and palliative sedations, one document on the Law 219 about the rules of informed consent and advanced planning care, and two position papers, one on the person with ALS and the revocation of informed consent under the Law 219, and the other one is on the person with ALS in emergency department. As said before, ISLA this year celebrates its 40 years by organizing a series of conferences, a real roadmap in 5 Italian cities with the aim of making known the palliative care in ALS, bioethic topics, and possible organizational health care model aimed at the care of the person affected by ALS. In this picture, you can see the posters of all the events. ISLA's work is explained in this document. The title is Why Palliative Care in ALS, the Appropriateness of a Care Model for Managing Complexity. We think that the person with ALS must be taken over by palliative care from the time of the diagnosis. 20% of ALS centers include palliative care specialists, And palliative care specialists, usually at an advanced stage, are introduced to patients and their families during treatment paths by the same ALS specialists. The crucial issue is that of integrating palliative care from the very beginning, that is to say, from the diagnosis. WHO definition of palliative care is quite well known. It's an approach that improves the quality of life of patients and their families who faces problems associated with life-threatening disease throughout prevention and relief of suffering. What does palliative care offer? They can offer short-term treatment for symptoms management, home support, physiotherapy, occupational therapy, spiritual and religion support, complementary therapies, daytime palliative services, family care, counseling, medical offices, and so on. The person affected by ALS has continuous requests because the disease causes him and his family many changes. For instance, in walking, in the ability to look after his body, in the strength of his voice, and in the difficulty to breathe and cough, until the complete withdrawal of the autonomous capacity to carry out these actions. Specialist palliative care deals with all these continuous and destructive changes. They accompany the sick people and their families in the serious losses so that they can be free to choose. But what does to be free to choose mean? It means that the patient must be able to decide which proposal, for example, for nutrition and breathing and communication, is suitable without having symptoms that disturb and distress. The patient must be sure to have a competent team with which can elaborate his choice in appropriate time for decisions after a complete and personalized communication. And that means that the person affected by ALS must be supported by a specialized palliative care team that is able to describe all the therapeutic possibilities for the acceptance or not acceptance of any therapeutic proposal involving the family and other involved people in all the steps of communication and choices. The specialist palliative care team must be able to integrate with the other specialists and with the other multidisciplinary team in order to act harmoniously. However, people with ALS can manifest conditions such as frontotemporal dementia or behavioral disorders. It is therefore necessary to document the goals and the treatment preferences of the person with ALS before an acute problem occurs, especially if respiratory, in order to anticipate future disabilities. Understanding the complexity of the care needs for the person with ALS makes it possible to distinguish between patients with the need of specialized palliative care from those who can be managed by general or primary palliative care. The process of assessing patient complexity can facilitate the analysis of the patient and his needs, the care preferences of families, and contribute to the shared decision-making process. In Italy, the protection of the person with ALS is implemented according to the principle of self-determination ratified by Law 219, allowing them to know and decide, not only in the here and now, but for the tomorrow and the day after tomorrow. This is the APC, which in Italy is defined as Shared Planning of Care, PCC, Article 5 of the law. The specific indication of the law provides for sharing a care planning which involves a true relationship between the person with ALS and the doctor in order to face complex and articulated paths. Treatment models of ALS must protect the person despite the poor prognosis and not modifiable clinic history due to the lack of effective therapies. except for instrumental support choices. In Italy, palliative care are regulated by Law 38 and are implemented in 4 settings: outpatient clinics, day hospice, home, residence or hospice, and hospital consultancy. The standard model of home care shows challenging limits, as the person affected by ALS and caregiver have access to neurological, physiatric, nutritional, respiratory, and psychological assessment and treatment skills, but they do not have enough space to address prospective support conditions such as treatment withdrawal, treatment waiver, and palliative sedation. The value of the integration of palliative care is also supported in the outpatient model, in which specialist palliative care can support other specialist care. The perspective of family members is that the family members are significantly more likely to know the patient's treatment preferences after early planning of care was completed with the patient. And they have a lower decision burden when they are aware of patient preference. I thank you very much.
Thank you so much. We do have some questions here.
Good morning
Kathy?
to everyone.
Yep.
Hi. Thank you. That was a great presentation. And my question is, sometimes when something's embedded in law and something is in practice, there's a little bit of a gap between the law and the practice. And I would just like your opinion on how well that gray area is navigated in your jurisdiction.
Yes, sometimes it's difficult to coincide the law and the clinical practice. We try to avoid that gap, trying to build with the family and the patient personalized steps of care, and try to include some medical in-law doctors that help us to reduce this gap. For instance, there's a problem with the dementia because they cannot choose. So the law just said to protect them. And protect them means that we have to talk a lot with the families to build the biography of this patient, which is a practical bioethical problem, because if one citizen is affected by ALS and dementia cannot choose, it's the healthcare team that must choose for him. And this is a really important gap that we try to reduce, talking with the family and try to build the story of the patient with them.
Yes, absolutely. Are there any other questions? Anything online? I think, adding another dimension to any clinics, adding this extra, the palliative care, I think adding extra care to people can be absolutely helpful. Definitely. All right.
Thanks a lot.
Thank you so much.
You're welcome.
And up next, we have Denise Harris with There's More to the Person Than MND, also virtually.
Sandria Harris, and today I'm presenting my chapter, which has been published, There is More to a Person Than Motor Neurone Disease. When a person is living with motor neurone disease, their temporality comes to the forefront. The lived-through past takes on new meaning in the present, and the future is anticipated with angst. In contrast to many MND studies, where the focus is on the person in the present and the impact of MND on the body, This published chapter explores a research journey and developed papers to propose a person-centred care model in M&D, focusing on individuality, which includes 3 major elements: 1, presuppositions, 2, acceptance, and 3, temporality. Presuppositions. Professionals must be aware of their presuppositions, which are pre-understanding and prejudices, to be open to the meaning of new perspectives. According to Gadamer, prejudice has to be provoked to be realised. Fleming et al. 2003 suggests that one approach to provoke presuppositions is to converse with a professional colleague. The process helps professionals enter the hermeneutic circle of understanding and remain orientated to being open to the opinion of the other, bearing in mind that performance is never fully achieved because it is constantly evolving. Gadamer 1975 recommends not trying to put oneself in the shoes of another person, because to do so is to ignore one's presuppositions and historical awareness. It is better to collaborate with someone to reach a shared understanding, otherwise termed as having a hermeneutic difference. The recommendation is to use this approach when understanding what is essential to a person with MND and accepting that understanding will change through time. Professionals must accept what shows itself rather than applying theories or their own professional ideas of what constitutes a person's needs. Professionals must accept that a person may wish to discuss loss, uncertainty, and other concerns. Such concerns about life and death are existential concerns, recognised and accepted in cancer care. Existential concerns are not recognised and accepted in M&D care until a person is referred to palliative care. The M&D Association 2016 guidance states that professionals caring for people with M&D are at risk of compassion fatigue, defined as emotional, physical, and spiritual exhaustion, because of witnessing and absorbing the problems of others. Professionals need to accept that a person may not want the illness trajectory of M&D, and they have the freedom to make choices to refuse treatments on how and where to die. Professionals must interpret a person in a wider temporal frame and beyond the context of their illness context. As Heidegger suggests, to ignore a person's past and future is subordinating that person to the present. Dewing 2008 calls for a reassessment of person-centred care nursing frameworks to take account of body and time, corporeality and temporality, if claiming allegiance with personhood. Corporeality and temporality are particularly important for a person as they first notice that something untoward is happening to their body. In the present, a person does not acknowledge their body because they mostly go about their daily lives and take their body for granted. They might be more likely to pay attention to their body when something untoward happens and it is not functioning as before. This occurrence may be a one-off, or it may be something more sinister. Whatever it is, it causes an episode of anxiety. People contact their deeper modes of temporality because of the present and the anticipated future. They reinterpret and define their past. Asking a person to tell their story about how M&D has affected all aspects of their existence through temporal time brings forward individual experiences. It provides a focus for person-centred care in M&D. In this next section of presentation, I'm going to talk about the temporal model of care. A person with M&D whose cognition is not affected is fully aware of their past. The memories cannot be removed, but the ability to communicate them can. The proposed model recognises that a person with MND has a unique history, culture and practice. The care process involves professionals enabling the person to talk about their lived-through past. The expected outcome: a person with MND will define their identities and find meaning in life as lived. It may help a person to talk about their regrets. A person with MND may experience the present in crisis because life with MND has no meaning. Frankl 1962 suggests that suffering people cannot move forward into the future. The proposed model respects a person as a self-interpreting being, existing in a social and cultural world with others, including family, friends, colleagues, carers, and the wider community. The care process involves listening to what is important for a person, and the expected outcomes: a person with MND will be determining their being as creating feelings of recognition, respect, and trust. A person with MND may wish to talk about the anticipated future and how to exert choice over the timing of death and achieve clarity over the legality of these options. The proposed model responds to a person's freedom and right to make choices. The care process should involve listening to their loss of a once projected future, their concerns for a future being unable to communicate, move and breathe at end of life, and their concerns for others. Their needs, priorities and preferences are understood and documented in an advance directive. The expected outcome: a person with MND will be facing death while still being in control. Thank you for listening to my presentation. Here are my references.
And sometimes people are ahead of me. Thank you so much, Denise. I don't know if you were able to listen in earlier today, but Helen and Sarah, our occupational therapists, talked about some of the same things, about looking at what is important to the person living with ALS-MND. Are there any questions from the audience here? Anything online? Okay, so I'll start. Give everyone time to think about it. So, I think this is a great idea because, especially people when they're first starting to work with someone. So is this something maybe new therapists, when they're starting to work in a multidisciplinary clinic or maybe even in their training, should be getting? Could you talk a little bit more about that?
Yeah, I do believe that would be a really good idea to introduce this model very early in the stage of learning for any disciplines, to be honest. It's quite a simple model in that it's understanding the person in this temporal frame, enabling the clinician, the therapist, whoever, to get to know the person, to have that documented on file, which is very relevant for when we're looking at their projected future. And so the professionals can get to know the person in more detail, get to know what they would want for their future, for their families, and getting all this documented very early on in the process in terms of advanced care planning. Then that can be put away and the person can be enabled then to live a quality of life.
Absolutely. Are there any other questions, or? We have a very quiet audience here today. All right, then I'm going to let you go, and then if anyone has any questions, they can follow up with her later. Thank you so much.
Thank you very much. Thank you.
It's a very, very long session. Absolutely. So next, we're going to move on to an international survey of patients treated by home mechanical ventilation to enable personalized care and maximize quality of life with Judy Livingston.
Good morning. Firstly, sorry we can't be there in person, but thank you for giving us this opportunity to present the results of our international survey, which looks at the outcomes that matter to patients, and importantly, how these results should be used to personalise the care of people with ALS who require home mechanical ventilation. My name's Jude Livingston, and I'm responsible for the ventilation programme within Air Liquide Healthcare. We conducted the survey across 12 countries where Air Liquide provides home care services. In total, over 3,600 patients responded, 656 of which had neuromuscular disease. Globally, across all of the disease types, the three most important outcomes were the same. That is, being able to breathe well, being able to sleep well, and feeling comfortable with the equipment. What is important here is the level of importance. That varied by disease, as did the order the outcome was selected. Communication was only seen in the top 6 for people with NMD, with 31% selecting this versus 13% for other disease types. As well as the variation in outcomes, we also found significant difference between patient types. We found that compared to non-neuromuscular disease patients, NMD patients were younger, 36% were below 45 years age, used their ventilation for more hours, 38% used it for more than 16 hours, and they also received more nursing care, 62% versus 27%. We also found differences in the outcomes selected between countries. Here we're looking at neuromuscular disease patients across 8 countries. We believe cultural differences and the type of ventilation, so invasive or non-invasive, influence this. These results have given us a great starting platform, but what is key to understand is why these outcomes were selected, how they interact and how they influence each other, and how we as a home care provider can positively influence them. I'd now like to hand over to David, our Director of Patient Quality of Life and a clinical psychologist. David.
Hello, everyone. Thank you. As you was mentioning, we wanted to, when we got these outcomes, these conclusions, we wanted to understand better what is happening, what is the relation with these outcomes. So we proposed to do and the best way to know this is to ask the patients, to ask the persons. So that's why we do this survey, these interviews. The purpose was getting feedback from the neuromuscular patients, the ALS patients also, on the results found. And then we wanted to, in the way we did is to do interviews by telephone or Meet interviews, Google Meet, to 5 patients, during 30, 45 minutes, and we took 2 caregivers also. This is the interview that we organized, we created. We wanted not to only ask directly about the outcomes, we wanted to understand what is the outcomes in the context of each patient. So there are 3 blocks about the life, how is the patient, what do you think about these outcomes, and how should we improve the mechanical ventilation. So we wanted to know, after to understanding the outcomes, what should be the way that we integrate these outcomes in our care plans. This is the characteristics of the 5 patients. We have 1 women and men, and from 27 to 64. And you can see different type of the therapies, all with mechanical ventilation, but with all other therapies like COX assist or aerosol therapy. It's very interesting to say when I present the results of the survey, and then I ask, what is the spontaneous reactions? They say the breathing is the most important thing. Depends how the disease affects you. This outcome is not the same depending on the status of the disease. Ventilation at the beginning is very scary. Many people look at, when the other people look at them, they think, I see the pity and worry and fear in their faces. And the family, the caregivers are key for this treatment. About what do you think about breathing well? I choose some conclusions. Some for me was very, very interesting reactions, answers. The most important thing to be able to live. And then other persons, he says, breathing influenced me to be able to speak as well. Sometimes I don't have the strength to speak. So it's not only a question of to live, it's a question that it affects other areas in your life. About being able to sleep well, they say this is the most important thing for me. From what I have experienced now, feeling comfortable allows me to sleep. So it's important thing, sleeping. This is more, I choose one question, but was one answer, but it was more or less all the patients were, the conclusion was that for all of them, sleeping well was key. About feeling comfortable with the equipment, with the device, they say that when they saw the device gives them, it's a wow, a lot of respect. But you need it. And if you is not adapted to you, or you are adapted to the device, you are not comfortable. It was very interesting this. Because they were saying that it's some kind of, what I understood from them is like, if you don't feel comfortable, you will not be able to breathe well, and you will not be able to sleep. So all the outcomes were not at the same level. It was more or less that you need to adapt, and then you will be able to achieve the other outcomes. About feel safe while using the ventilator, they say if you don't feel safe, you cannot be comfortable and you cannot sleep. It was very interesting to see how they were able to asking the patients, they were connecting all these outcomes between them. And about feeling control on my treatment, the patient, he prefers to talk about having control of my illness. It's not really the treatment. They feel that treatment and illness, the disease, is connected. So we cannot understand the things independently. We need to understand what is the context, the status of the disease, and then we will be able to understand what is the status of the treatment. The global impression of the outcomes is that the main barrier they found to improve these outcomes is the disease itself. It's a progressive disease, so you need to be able to adapt all the time. And the adaptation is in both senses, the treatment to the disease and the disease to the treatment all the time. So it's really, it's more complex. We cannot, as I mentioned, we cannot understand the treatment independently of the treatment, of the disease. Other thing that they mentioned is the shock, how the therapy was presented. There was some kind of lack of communication. You need this, and they put, and they need, they present the therapy to the relatives before to the patient, and they would like to be part of this discussion from the beginning. This is connected about the communication, empathy is super important, and they found that they are lucky with the people, the healthcare providers. They feel like it, but the most important thing that they found from them is the communication, the empathy. And they mentioned one important thing. Okay, these outcomes that you found in the survey depends of the situation that you have in the disease. It's not that if you don't have symptoms and you are in the advanced, maybe these outcomes will change. The conclusion from the patient's perspective is that sleeping is something that everyone has worried. So we need to take into account the sleeping, with of course breathing, but the sleeping is key for the patients that they have this treatment. The outcomes are related to each other, and it's some kind of, as I mentioned when I was explaining the results, it's like some kind of connection between cause and effect between them. And this improvement of the outcomes is related to the feeling in control of the treatment. So information, training, and adaptation to the device, and the adaptation of the device to the patient is important. So for me, there is one sentence, the right treatment in the right moment for the right patient. So this is super important. So we need to understand the patient to be able to see when he needs the treatment and adaptation, and then we will provide the best treatment. Three topics, three conclusions: training, coordination from hospital, and different persons, we need to individualize of the treatment. What we have learned, and when we try, after these interviews and the conclusion, we sit all together, Jude and I, all the team, we say, okay, now what we have learned. If tomorrow we want to deliver a personal escape plan, what we have learned with the ALS, with patients with ALS. We have the diagnosis, and not all the patients have the same status. So we need to understand what is the functional status. Taking into account this, we need to empower the patient and the caregiver It's super important to empower. And when we talk about empower, we are talking about information, training, communication, empathy. We talk about all these things. And we need to take into account other part of the context. It's in orange, the non-modificable influences. It's not the same if you live in a small town, in a big town. It's not the same if you live in a country when you have a lot of healthcare resources and you have a country when you don't have it. So we need to take into account this context also. After the empowerment, we will be able to achieve the first two outcomes that matters to patients: comfortable with equipment, feeling safe. In the moment that we achieve this is when we will be able to get good adherence to the treatment, good clinical outcomes, AHI, reduce the leaks, reduce the anxiety, and promote the caregiver implication. And thanks to that is when we will achieve good clinical outcomes and the other outcomes that matter to patients: breathe well, sleep well, minimize emergency services. And that is when we will be able to maximize the quality of life. So this schema is super important to understand, that help us to understand which actions we need to do. Treatment with mechanical ventilation in ALS patients is not a punctual and only one single moment. It's a process with different stages. What we propose after this is it's necessary to create this proactive care management program. We need to create outcome-driven care plans. If the outcomes are okay, is when we know that we are doing the things in the right way. It's not only a question of clinical outcomes. It's not only a question to have good saturation. It's a question of feel comfortable, feel safe, sleep well. So to maximize this quality of life, we proposed this personalized care plan with these 5 pillars. We need to information provision, patient navigation, help the patient to move, this coordination between hospital and home, care coordination. We need to be coordinated, all of us. At home, we are the bridge. We need to help the patient and the caregiver to connect with the hospital. Process monitoring. We need to check the right outcomes to be able to adapt the care plan depending on the status of the outcomes. And we need to do then this proactive monitoring and of early detection of signs and symptoms. We cannot wait until the problem is big. We need to be able to detect early when there is a problem. So what are the key takeaways? What we'd like to share with you all this experience, because at the end, we really like to, what we have, the care plan that we are building, because we did from scratch, but going from the patient's voice, for the patient point of view. With what we have learned is that to do these personalized care plans, we need to take into account the patient situation, what is the status, what is the context, and we need to create profiles. The profile is a generic cluster of groups of patients, but we need to be able to see what are the right profiles. And we need to adapt this care plan according to the status of the outcomes. So thank you.
Thank you so much, and thank you, Judith, for joining us. Are there any questions to start out? There are some questions. There's one down here. There's one over there. I'll start while they get the microphones. First of all, this was fantastic. Such a large study and such a lot of great information. Since communication was such an important piece to people, is there any looking at the masks to enable like a microphone or incorporate some way that people can still communicate?
I'll be honest, we haven't actually taken this to look at what impact it has on equipment, but actually you raise a very good point that often it is the mask and the equipment itself that impedes that communication. So actually you've triggered something now that I can certainly take to my counterparts in the companies that manufacture the devices to say, hang on, what can we do here? I think that's a very good point.
Thank you. And who has the microphone over here?
Thank you for the presentation. My name is Tommy. I'm based in the Netherlands. I was wondering, you had quite a lot of people globally that using non-invasive ventilation, and you have interviewed like 5 people on top of my head. Like, Do you, or can you show some light on the effect it had where people were living across the globe, or did you had like these 5 people were there from a certain region, and do you think that will the region where they live that will reflect, or that will be reflective in their answering?
Certainly the country had a huge impact, or we believe it does, in terms of the global outcomes. The interviews that we have presented you today, they were all from Spain. So David, who's Spanish, kind of was able to use his network to carry out those interviews. But I do believe that if we were to take 5 more patients from, let's say, South Korea, where we noticed that the outcomes selected were very different to those that we saw in Europe, I think we would see different, or get different feedback from those patients. And we believe that difference is both cultural, but it's also potentially linked to the use of invasive ventilation versus non-invasive. So if we looked at what equipment patients had and how they were using the ventilation, we could see the difference between the outcomes that were selected. So I don't know if that answers your question.
Yes.
Hi, Euphrosyna Young from SUNY Upstate, Syracuse, New York. My question is very specific for non-invasive home mechanical ventilation. When you defined patients that reacted in a way that the use of home mechanical ventilation is felt to be unsafe, I wondered what are the variables that contribute to that feeling of being unsafe with home mechanical ventilation? Let's say there are patients that have very poorly controlled oral secretions. There are patients that have loss of mobility and loss of arm function particularly, and they're not able to adjust the mask, for example. Are those the type of patients that are reporting to be unsafe? And because your patient population that responded to the survey are from Spain, and I understand that there are regional differences and geographic differences, are these patients having access to care of home care respiratory therapists that are able to assist, with problems, troubleshooting for, any issues with the mask, with secretions, with titrating the mechanical ventilation settings? I mean, what is the type of intervention that's happening in the homes? Thank you.
Okay, so maybe if I start with the type of support all the patients involved in the survey had. So we were only able to conduct the survey where we as a home care provider currently do these services. So we went directly to the patients that we currently manage. So in terms of that, they already had a home care provision. But the home care provision today is very limited, and we walk in the door and we look at the device as opposed to the whole patient and how the device works with them. And that's really what drove us to do this survey. It was interesting when we did the word wanting to feel safe came across from all countries. So it's clearly a feeling that people with ALS, they want to feel safe. Now, when we did the interviews in Spain, nobody said, I feel unsafe, but they want to feel safe. And I think for all of us to assess that, I think one of the key drivers is really looking at their home environment in terms of the level of support the patient receives. So, for instance, one of the patients in the interview, his father was actually a doctor. So for him, safety wasn't an issue because he almost had a doctor in the bedroom next door all 24 hours. But for other patients who maybe lived alone, they had access to us via the telephone with help with the device. But really it's that I'm here in my house on my own. Somebody may come and give me some care, maybe a few hours a day. But away from that, do I feel secure enough? And the other thing as well was also the knowledge about the treatment. So people are given ventilation. Most patients today are initiated in the hospital environment, and there you probably feel safe. You're surrounded by medical staff. But when you go home, it's a big change. And it's how we support the patients. And David talked about the empowerment, so that caregivers and patients feel empowered and really understand that they can control their treatment as well. And that's why we believe that really the empowerment is what drives patients, and the knowledge and the training to help people feel safe when they do go home.
Excellent. Anyone else? All right, then we're going to go ahead and thank you very much for this excellent presentation.
Thank you very much.
And up next, let's welcome Susan Brumbury for Unveiling the Silent Journey, the Deceptive Comfort of BiPAP in MND from Fatigue Relief to Choosing the Final Farewell.
G'day everyone, I'm Susan from Australia and I work as a physiotherapist in our local community. I actually live on the tiny island that you would find on the bottom of Australia, and our population is about 500,000 people. My main area of work is in respiratory health and respiratory physio, so I do a lot of work with the BiPAP machine and with clients who have motor neuron disease. As we know, motor neuron disease is a relentless condition. It's a condition that results in continuous changes and adaptations to every element of that person's life who is diagnosed, from eating, drinking, sleeping, their job, their friendships, their relationships, you name it, every element. We see this condition slowly strip away elements of a person, their identity, and then they are left with a body that no longer works like it used to, and a mind filled with questions of the future and what is to come. One of the vital companions in this journey for a lot of people is the BiPAP machine, and I'm well aware in this room that maybe not everyone knows what a BiPAP machine is, but I think most of us know what obstructive sleep apnea is. And in order to treat obstructive sleep apnea, we use the overnight breathing machine or the CPAP device. And the CPAP device delivers a continuous positive airway pressure from the machine to allow that person to ventilate well as they sleep. BiPAP can be also used to treat obstructive sleep apnea in some cases. It is very similar in its mechanism, but it uses two different pressures. One pressure as you breathe in, and a second pressure as you breathe out, just so you can get an idea of it. When a patient's first introduced to BiPAP, it can be a beacon of hope. It can help them with their sleep quality, their fatigue, which we've heard over the last couple of days is a huge element of the condition. And it can also help to bring a little bit of life back into the body. It also helps with the dreaded feeling of breathlessness. For some people, they're at that stage of their condition. But as motor neuron disease evolves, so does the purpose of this machine. Because of the muscle weakness that comes with their condition, the BiPAP machine starts off as a device promising hope, and then it subtly shifts into a machine that is providing full-blown long-term ventilation. We don't have a lot of, in my state, we don't have, I think, anyone who's tracheostomized for their ventilation, so we do rely on the BiPAP machine for that. This shift in the roll of the machine, it's so slow, it's hardly noticeable. And it's hard to pick up a very defined line of when it was helping with sleep to now being a full-blown ventilatory support. The challenging thing with this is when that shift happens, you finally realize that the person is now deciding the day to remove the mask to end their life. Sorry, I forgot I had to do those. I had a client last year, I'm just going to call her Catherine, just to protect her identity. Catherine, when we met, she was on her BiPAP machine 24 hours a day, 7 days a week, and she couldn't really come off of it for any more than about 10 to 15 seconds. And even the use of things like oral morphine were not really giving us much more time. So I was asked to go around and see Catherine one night. She was having a lot of trouble with secretions getting caught in the back of her throat because the drugs that she was on was causing them to become really thick and also get really stuck. And I just remember going around to her house and heading into her lounge room. This is like the perfect space, actually. And she was sitting in her electric wheelchair with her eye gaze machine, and there was an empty seat next to her for me. I walked in and sat down, and she started typing on her eye gaze machine. I've got a question that I really want to ask you. And me, in my casual nature, just went, sure, go for it. And she continued to type this. What happens when my BiPAP mask comes off? And I just stopped for a second. And I looked at her and said, do you mean for good? And she nodded. Whoa, what a question. I sat for a long time. And then I proceeded to answer. But the words that I used were cold. They were clinical. And I feel like now, in reflection, that they fell short of they fell short of what her question demanded, the answer her question demanded. So that evening, I went home, and in the car, the weight of the interaction with Catherine really settled in. And when I got home, I posed this question to my husband so we could talk about it. He nudged me to see beyond the surface of this question and prompted deeper introspection. He asked me, was your patient asking you what was clinically going to happen? Or was she asking you what she was going to experience? I said, it's my second R moment for the day. It was what she was going to experience. We talked about this topic for most of the night, as I felt like I needed to understand the layers that this question held, the emotional, psychological layers. Because this is not going to be the first and only time that I or us are going to be presented with this kind of question. And I really wanted to get it right. It's just part of my personality. So at the end of the night, my husband and I, we wrote a script. That was important because I was due to see Catherine the next day. When I got round to Catherine, she was in her bedroom this time, and I sat down on the edge of her bed. I held her hand and I apologised for my first attempt at answering her question, and asked her if I could try again. She nodded. And this is what I said to her. At some point, you're going to make a decision that it's time to go. And when you do, and you are ready, you'll take medication which prevents the sensation of being short of breath. Then when the machine is turned off, you'll slowly run out of air. It won't hurt. You'll just get sleepy. And after a while, you'll go to sleep. I cried. She cried. And then I had to clean up the mess of the crying, because when you cry, you over-salivate. So as a respiratory physio, it took a while to clean that up. I could see, though, in her eyes, because she couldn't tell me, that some of her worry and fears have been eased. And it was nice to know, and I saw this again in her face, that I had spoken to her like a person, a human being, and a friend. But this situation got me thinking of many things. How do we navigate informed consent with a BiPAP machine and its evolving role? And what does it truly mean to be informed when embarking on this treatment journey? For me, I think being informed goes beyond knowing the mechanics of the machine. I think informed consent is about understanding the long-term implications of this kind of treatment, the evolving role of the machine, and most importantly, the choices and decisions that may lay ahead in the future. BiPAP isn't just a clinical conversation, and as you've heard from my experience with Catherine, it's an emotional, psychological, and ethical conversation. And that conversation needs to be navigated with care, empathy, and utmost transparency. Because we're talking about a machine that helps with fatigue relief, but we're also talking about that exact same machine deciding the day that that person will remove the mask and end their life. So, how do we have this conversation? How do you talk about, in 1 or 2 clinical consults, the benefits, and hold them in one hand and talk to your patient about those benefits, whilst at the exact same time having knowledge of the day that that hope will be gone, and that day will be the most challenging day of their lives and the lives of their friends and their families. So another question came up for me. Who should have this conversation? And when I thought about Catherine's case, I came up with 14 health professionals who were involved in her care at that time. And I think we've all experienced this, and correct me if I'm wrong, but we have this assumption that somebody else is going to have this conversation. So we assume it's already happened. Oh, that's your job, that's your responsibility, that's your role. And as you can tell, no one had had the conversation in a way that Catherine understood. Given my experience, I now, as soon as the word BiPAP comes up, I am actively engaged in this conversation. It's a hard conversation to have. There's always tears. I've had people storm out of my office, but then have come back 2 or 3 months later and have said that they are grateful for that honesty. There's something, though, about being a physio, an allied professional, that I've noticed over my career. Your patients love to tell you everything. Things that really they should tell their husband and wife or even the doctor. But you get the whole story, all details. And trust me, it is all details. And I thought about that. What is that? Why us? And I thought, well, we're a profession that engages in human contact, human touch. And I think that unlocks the door to human connection and trust. And that allows us into that vulnerable space to have these difficult conversations. So in conclusion, as the world of medicine advances, we should not only be aiming for treatment or pharmacological breakthroughs. Equally vital is the evolution in the art of communication and connection. I would love to see a world where every patient feels like their clinician is not just a dispenser of clinical knowledge, but a fellow traveller in the journey of life. So, my question to everyone here. Next time we are with a patient and you get faced with a difficult conversation, I want you to ask yourself, who are you? Who are you being? Are you being a clinician? Or are you being human? Or do we need to find somewhere in between? Thank you.
Thank you so much for that excellent presentation. I'm sure there's going to be questions. I see one right up here. I think, yeah, go ahead. Oh, there's two up here. Okay, Allison has it. It should work if you just start talking. Or we switch out microphones.
Thank you. Okay. Oh, yeah, that's better. Yeah, Susan, thank you for that beautiful presentation and the way that you framed that conversation. It was so perfect. And so my question for you is, you did such a brilliant job in answering the true question that you heard, not the question that was necessarily communicated to you. And so you created a sense of understanding for Catherine. My question is, what support can you offer once that understanding occurs? Because that's a really difficult moment in time. That's two parts. It's understanding that answer and then coping with that answer as well.
For me, I think it's just making sure that we follow up on these conversations. And just asking the patient how they're feeling about it all. Like, we're very, the word's clinical, but it's very cut and dry and, you know, black and white, and we're not delving into these emotional conversations enough, I don't think. And how do you feel about the conversation we had yesterday? Was that challenging for you? Because it was challenging for me, and just having that interaction on a human level, humanity level, and being real with your patients. I think they respect that, but definitely following up with it and where their headspace is at. And then if it's not settled, and honestly I don't think it ever will be, their headspace will be settled on a question like that, you just keep following up.
And are there other team members then that you could, like, we have a mental health specialist, so if I feel like it's outside of my comfort zone, I've stepped maybe too far, or they've asked me a question I can't answer, then I would refer them to her.
Definitely. You know, the use of the, you know, in Australia we have our support coordinators, we have our social workers, we even have support networks within the palliative care team as well. So we do have a lot of options. We are very blessed. Yeah.
And Rick, do you still have a question? Down here in the front, in the gentleman in the wheelchair with the pink flamingos all over his legs.
Thank you. I just wanted to say thank you, because today you had that conversation with me. And I am now completely settled, sorted. I do thank you.
So welcome.
I think you're such a courageous person, and I admire you immensely. Thank you for coming and talking about this.
You're very, very welcome.
All right. Thank you, Rick, for making us all cry now. There is an online question.
This is from Kevin Robinson from Niels. He says, you carry a heavy load. Who do you talk with, and where do you get support within the system?
I actually have a clinical psychologist that I see on a regular basis because it is heavy work and there's only so much of your own bucket. I'm not sure if you guys have heard about the bucket analogy in health. You can only give out so much and then you have to learn how to refill your bucket. So I generally check in with a clinical psychologist once a month. But if I also get a difficult case, because I also work in pediatrics and I also have a 4.5-year-old daughter, so there are lots of parallels there, I'll just book an appointment and a session and have a debrief. I also have an extremely supportive husband, and he is always, as you can tell, he's always willing to help me understand situations on a very deep level, and I get a lot of support from him as well. Yeah.
And I believe there's one more question over here.
Yeah, Gudjon from Iceland. Thank you for this, but should this not be addressed when you get the machine? So it's part of the process that you get it to breathe, and when you park it or take it off, you die.
It's a very complex system where we are, and as you saw by the list of people, we have a, who's going to have that conversation? And it could be the neurological consultant, the neurological nurse, the respiratory consultant, respiratory nurse. Then we subcontract out of our hospital system to another company to actually set up the machines. And then someone like me is involved. But it definitely needs to be somewhere in those initial conversations, for sure. Yeah. Definitely.
All right. Thank you for the excellent questions, and thank you so much for this presentation. You might get more questions.
Thank you.
Thank you so much. It's time to move to the final presentation, which is a quick one.
I'm actually looking pleadingly at Jen, please. I'm just going to... It doesn't count towards the time. I'm just...
Oh, it counts. Oh, yeah. Nice try, though.
Honestly, I feel like I'm level set this morning. I feel like I'm in the right place. I feel joy that I'm a speech therapist. I feel loved that I'm working with people living with ALS, MND for the communities that I serve. And I just want to thank all the speakers. I wasn't planning on saying any of this. I was planning on talking about other stuff. Oh, look. And it's not even showing my screen. Technologists. Right. Well, I'll keep talking while you've got my screensaver up on the screen. So I'm a speech therapist. I'm based in London. I work with the MND Association. I work with Google as well, and I'm doing a PhD, which is killing me. And it's all about the same thing. It's all about using technology for people living with MND. It's people with MND ALS first, technology second, and that's how it will always be. And so I've come here to not only talk about a really exciting technology which has just come out, which is co-designed by people living with MND. Please, please. Thank you. I have my beautiful assistant here. It's an art for expression tool. AI, that term is everywhere. So it's here as well. So it's an artificial intelligence art for expression tool that we road tested with people with MND across the progression. And they can type in anything they like. And they've used it in really interesting ways. So they type in whatever they like using eye gaze, switch, head mouse, direct access, any combination. And they use it in different ways, 5 different ways so far. The first is just for fun. I'll just type in a message and an image will come out, and that's just really great. Another one is to share, it's just kind of self-reflection, to help, to generate art to help themselves. Now these are use cases that have come from people with MND, not from me. Another one's to share how they feel. And you know, it really, I am no artist, but it really is, I really get it, that a painting's worth 1,000 words. I think it's worth more, particularly if you're an eye gaze user, when you can only do like 10 words a minute, maybe. And so this is very powerful stuff. The other thing was people used it to show who they are. They're still the same person. To prove, to demonstrate competence, that behind all this, I'm still the same person. I'm going to use art to show you I'm competent. So that, I can demonstrate that out in the hallway, and I'm going to talk a lot about that tomorrow, along with AI, and how we, all of us, are not yet included in the AI discussion, and neither of our patients, as far as I can see, and that has to change. The other thing I wasn't planning on saying was about voice banking, but my name was mentioned, so I felt like I have to. So I deliver voice banking in the UK, and I help the folks in Australia every so often, and I'm published on it, and I'm an advisor to Royal College. So I have the emotional scars. I have an opinion on this. And my opinion, I agree, I was so delighted to have John, so delighted. I loved your presentation, Nicholas. I loved it. And what you said was, we all need to be involved. We need to be part of the co-design, we need to give feedback, and that is 100% right. The problem is that we have new technology coming through, and I feel we're not involved. Like with Apple Personal Voice, this is the first voice banking software that is completely free. It's completely free, and it's available to us all. But there's a problem, because folks like me and Nicholas and anybody who is kind of an international audience, and I feel I can say this because this is an international audience event, and we want to be inclusive. That's why we're here. It's very focused, it's very US focused, and I can see that because the phrases that people are asked to say are US specific, long phrases, complex phrases, US spelling, and you cannot skip any of them. And I just feel like if all of us together, wow, that's great, I haven't got a warning. If I'm going to rephrase that. If all of us together advised Apple, all of us, then it would be a different product. And if all of our patients, all of our clients, people living with MDLS, also advise Apple, it would be different. I guarantee it. Because when we pool our minds, we don't have to be brilliant, we just have to be there. We come up with brilliant things. That's what co-design is. That's what we have centuries of experience, and that's not including our clients. The other thing is, I have a stand. I'm not looking over there. I have a stand over there. I'm going to demonstrate 8 free apps. They're completely free. Eye gaze, facial gesture, stuff like that, more stuff like that. They're all free, and I'll demonstrate them all for you. I'll also demonstrate Relate, which is a new tool to caption dysarthric speech. And I'm pushing my luck, so I'm going to...
I won't have to stop you. You're between them and lunch.
Enjoy your lunch.
So please stop and see Richard's demonstration out there in the foyer. He'll be available for people. So now I'd like to invite up Jamie Piggott from the ALS Hope Foundation, who is our lunch sponsor. Rich.
I'm actually going to have we have time for 20 minutes before lunch. Is that okay?
Yeah.
All right, that's good.
We'll all just walk out or roll out.
Well, you might walk out when you hear this joke. Do I have any nurses in here? Why do nurses carry red crayons? Why do nurses carry red crayons? To draw blood.
Yes, every day I have to hear these jokes.
I'll be here all week. Thank you, Sarah. On behalf of Dr. Terry Hyman Patterson, Donna Harris, Sarah Feldman, our collaborators, Jean and Cassandra, and Dave from your ALS Guide, I just want to welcome everybody here. Last year, I quoted Walt Whitman, who said, "Be curious, not judgmental, and extend yourselves and learn a little bit." This year, I'm going to quote author and writer Trent Crimm from The Independent, who said, "Extend yourself. Do yourselves a favor, and whatever you learn, even if it's one thing this week that you have learned, please take it back to your hospitals, your clinics, to your patients, to the people that you take care of. One thing that you learn, because that will make a difference in what we're trying to do. We want to continue to move the needle forward. We want to continue to make a difference. So thank you." Really quickly, because Terry is probably listening right now, and if I don't address it, I just want to say that the ALS Hope Foundation was started by Dr. Terry Hyman Patterson and Dr. Jeffrey Deitch in 1999. They joined the International Alliance the following year, and they were full members by 2001. They were both fully committed to the international mission and saw the importance of the alliance. When the Allied Professionals Forum was added in 2003, they were both full in and put their support fully behind it. The team was encouraged to attend and present. So like Donna, right? And Mark and Sarah. Sarah joined the committee in when?
I don't even know. I don't know.
Okay.
It's been a long time.
A long time, but you became the co-chair in 2015, correct?
2015.
Yeah. We are proud to be how the APF has grown, and especially proud on how many allied health professionals over the years have attended and left with knowledge of tools and also friendships. We at the ALS Hope Foundation will support the APF for as long as there is a need for it, and you will always have our full support from the ALS Hope Foundation. I'm also available for any other jokes that you may want to have during the week. But please remember what Trent Crimm said, and that is, extend yourself. Take something back with you, and our patients would love it, our families would love it, and our caregivers would love it. So thank you very much. Enjoy your lunch. Your lunch is ready, and we will see you soon.
Thank you so much, Jamie. And that does bring us to the end of this very long session. Thank you for having me as your moderator. We will be back here at 1:45, so please make your way to lunch. As another note, the physical therapist and occupational therapist will be meeting directly after the meeting this evening, somewhere out there. But if anyone else wants to make plans, please just let us know and we'll announce it.